it was epidemic. Similar cases occurring in the vicinity. So most likely it is arbovirus. So relatively preserved inflammatory markers with dense encephalopathy without multi-system involvement, no other systems involved, with no progression of seizure suggests arbovirus like JE. However, autoimmune encephalitis cannot be ruled out. So when to suspect JE, anybody?
More than during rainy season, coming from an epidemic area, less than 15 years, 5 to 15 years is the area. During monsoon time, he should be coming from a rural area where you will have more amount of pigs with mosquitoes and who are proximal to cattle. And he will present basically with fever with altered sensorium.
Also adults who are not staying in a JE endemic country, when they come, they are also very prone because they don't have any protection against JE. And what is not JE? What are the things when you find, then you will say this is not JE.
When there is rash.
One very important is rash. Japanese encephalitis never comes with a rash. So whenever any encephalitis, if there is a rash, then it is not Japanese encephalitis. So do you have JE in Delhi?
Yes.
I was astonished to see the North District of Delhi is declared as endemic for JE. And not only that, these are the 12 sentinel centers in Delhi where you have the facilities to do a JE examination. Unfortunately, all the PCR tests in CSF is developed in the Western countries.
Sir, currently the footprints of JE are increasing. So this list, now you had 171 districts, now this is more than 350 districts
Yes.
of the country are JE endemic.
Now, I am talking about JE in Delhi. So it's common in Delhi. I don't know whether do you find it, because what we do, we send PCR. PCR can detect so many things, so many bacteria, so many viruses, excepting JE. As because the JE does not occur in Western countries, so not a single PCR has been developed to pick up JE. So we detect JE by doing an antibody test. So, and this is the neuroimaging. What in neuroimaging you usually find? One of the panelists, please tell. It is the thalamus, basal ganglia, midbrain, pons. These are the 5 important things that usually they involve in JE. A CT scan or an MRI will be very much important to diagnose. And when to collect samples. For virus isolation, we never do virus isolation. So for IgM antibodies we detect 4 to 7 days after the onset of symptom we do. And 2 samples are preferred, but we never do 2 samples. We do 1 sample. CSF is preferred over blood sample because antibodies may be present in the blood.
5 minutes are still there, so we'll finish in time. One more thing which I wanted to add is that most of the time we go for neuroimaging, especially when we are having acute encephalitic syndrome, rather than going and simultaneously sending the investigation. So many times these things are actually picked up. JE has been picked up on MRI and
yes, that's right.
imaging. That's what is there. That's why I said yes,
and
because that's where we had picked up.
And remember one thing, JE is a very bad disease. Either only 30% of the child suffering from JE will go away without any problem. Rest will have either lifelong disability or death. So this is, you see 30% death, 30% residual disability, very severe disability is left, and only 40% will go away without anything. So in our case, you should always remember this series of action. Which one is the most important of these? Which one you would like to manage first?
So first is, as it starts, ABC and stabilizing cardiorespiratory status, and then management of seizures.
Seizures is very important.
Yes.
Unless you manage seizures properly, there will be permanent brain damage. So CSF was done, protein was 100, sugar cells were only 10 cells. So remember one thing, absence of cells in the CSF does not rule out meningitis. So whenever you come across such a case before diagnosis, what is the combination therapy you would like to give?
Ceftriaxone, artesunate and
Yes,
acyclovir
that's
in
right.
the area.
So
So combination.
give this. So what tests for JE? Of all the tests, we do
CSF, IgM.
IgM test we do. And do you need to do EEG? Answer is no.
No.
One important thing I'd like to show you. The case infection ratio in JE is 300 to 1. That means if 300 patients are of JE, only one will develop signs and symptoms. Compared with dengue, if it is an immune, 100 is to 1. All ages are affected, but more common in children. Case fatality is as high as 20 to 50%, but in dengue is less than 1% with supportive treatment. So you should realize the importance of JE. Mainly children are involved, does not spread from child to child because JE virus is if it infects the human, it is an end stage of the spread. So it is from the pigs to the child. Now what has been seen,
Why a mosquito?
these JE mosquito culex, they are anthrophilic, they are zoophilic, they preference more for animals rather than human beings, and they bite at night. So if the cattle ratio is high to pigs, then the chance is less because they will bite more of the cattle, not the children. And staying very close proximity will do. But I'm on my last slide. So clinical spectrum, asymptomatic, mild, moderate, severe, 30% death, 30% will severe to moderate disability, and less 40% will escape. So these are the 3 stages of JE. You can have it in any textbook, nothing. And take home message is standard care can prevent death but can't prevent morbidity. So every children should be given a JE vaccine, and it's a cheap vaccine, 2 doses starting from 1 year age, 1 month apart. So thank you for your patient hearing.
So the vaccine part is very important. Never ignore the possibility of JE in your proximity and the areas. Even in the urban centers, don't ignore the vaccination. Thank you.
So, Chairperson sir, if you want to give some comments.
It's a very well elaborated talk by Dr. Gundu. It was very enlightening to the audience and to everyone.
Thank you.